Afternoon, everyone. Can you hear me? Okay. Hi. Let me share my screen. Okay. All right. First off, I'd like to thank Dr. Joel Beleno for inviting me. I think this has been a partnership 3 years in the making already. Thank you for always accommodating us, and I'm very happy to be with you all today. Thank you, Alan and Patricia, also for the kind words. I am definitely far from being an icon, but but I will try to give a few bits and tips, probably on the health research agenda that Dr. Joel Belen and the rest of the health research unit and all of the departments work so tirelessly on. If you will see my screen, I actually entitled the slide as leading and sustaining. As I was looking through the agenda that was set by ITRMC, I really felt the commitment of the hospital in terms of leading in the region, and committing to sustaining research, not only in the region but also in the national scale. So I hope I can be able to give some comments on that for this afternoon. So maybe just to give some context on how I will react. I do realize that ITRMC is a big training institution, and it's really a pioneer medical center in the region. And with that um, perspective in mind, no, is what I have designed the comments that I would give as the agenda is concerned. I will also look into or give some comments on the topics and reactions, but I think the bulk of my reaction will really be on the implementation, dissemination, and utilization part of research, with some favoritism on the quality improvement and patient safety aspect of things. As you all have heard earlier, it's actually when or the topic which made Dr. Beleno and I cross paths is the AHEAD program on patient safety. So just some notes that were really glaring for me as far as the HRA presentation is concerned is that many of the research, the non-MTRA research that were conducted in hospitals were as part of training requirement. And PGH and ITRMC are very common or very much alike in the sense that a lot of our research are really the result of the training requirements of our residency programs. But as Dr. Joel mentioned, it's high time to really align those researches and make sure that they're actually serving a purpose rather than just a requirement. Areas of established health service delivery are underrepresented in the implemented researches. That is definitely something that we would like to, I think the HRA would definitely need to address. There's a wide array of research areas, and I'm happy that based on the presentation earlier, that the ITRMC group was able to really streamline its core priorities for the hospital. And in many of my engagements, I really make it a point to emphasize this, is that research effort should be accompanied always by utilization and dissemination activity. So that's also something that was mentioned earlier. So these are the priority research areas for ITRMC, and I'm sure you remember all of the specific topics that Dr. Beleno mentioned earlier. But I did want to see just on the macro or higher level what the research agenda was or is going to be for the next few years. And so first I would like to really applaud the group for many reasons. First of all is the consultative process. I think as with any endeavor, a consultative process always ensures engagement and not just adherence. So when people have the buy-in from the research agenda, it's more likely that the research agenda becomes a reality. So I really applaud the group for having taken the time and effort to consult all of the clinical, non-clinical, and allied departments. I think that's something that should be emulated by other institutions. Um, and the other thing that I would also like to share with the group is that I'm very much impressed with the research topics and focus that was clearly laid out in the health research agenda, particularly because it answers the quadruple aim of healthcare in healthcare. This has been triple aim before, but has been updated, I think, in the last 6 years to quadruple aim in healthcare. So it's not just about improving outcomes, lowering costs, and looking at improving patient experiences, but also now looking into the safety of your healthcare workers. And I would even challenge the group that it's not just about safety of your healthcare workers, but also the joy or promoting joy in healthcare work, especially in the face of more than a year-long pandemic. How are we taking care of our healthcare workers, not just making them safe, but still finding joy in the work that they do? And that's actually what the quadruple aim is really all about. Um, One thing about the research areas that were presented that might be quite useful for the group is that I think it will be helpful to match priority topics with available resources in the departments, not only to implement research, but looking ahead and seeing already where your resources are as far as sustaining implementation of the solutions that you will actually formulate after doing the research. So whenever we try to plan out researches, it's really planning out what the next steps of the research will be. After we get the data, what do we do with the data? And those are the solutions, the policy or the data-driven policy approach that Dr. Beleno and Alan were talking about earlier. So it's nice if you have, for example, you've talked about like having a genomic center. That's really a commendable mission, but definitely be able to to match your resources with your aim as far as research is concerned. So just because, as I said, most of the researches that are being produced in our hospitals nowadays are a part of requirements for residency or fellowship training. I'd like to share with you some unpublished data. This was a survey that we did among IM, internal medicine residents in all accredited training institutions in the country. So if you will see their outputs, no, out of all of the researches that actually I think it's about almost 800 researches that were produced by these IM residents, only 5.4% actually made it to publication, with 3.2% being published in international journals. 20% were presented in research fora, 3.8% of those in international fora. So what you will see here is there's a lot of push for us training institutions, for our trainees to do research. But we hope that with that push, there's really better productivity amongst the researches that are being generated in the institution. And if we also look at actually the resources that enable these residents to produce these researches, 85% of them said that that they were provided structured learning sessions on research, and that's a really good news. However, 60% of residents actually spend around 5 to 10,000 pesos per person on research, whatever that cost may be, and even 5% of them actually spent more than 10,000 pesos, and around 75% of them do not have protected time for research. So what I'm saying probably in this slide is that we want to increase productivity. We want to also increase dissemination of those researches, but definitely resources and support for producing research is really needed, especially for our trainees. One of the striking questions to us in this survey was, when we asked them, when we asked residents, would you still conduct a research project if it were not required during residency training? Around 40% of them said no. That's actually quite revealing and tells us what do we really need to do as far as research requirements in training is concerned. We are delighted to hear about the 60%, but definitely there is a need for us to more or effectively communicate what research requirements are all about and how does that contribute to research to residency training. So just building on that, these are some of the things that I'd like to share with the group, is that with the research agenda that you've put in for the hospital, it's really important that we invest in building the infrastructure for research. And that's why I entitled this as leading and sustaining, because I think the infrastructure will definitely push ITRMC to be a leader and maintaining that leadership in research. So these are just some of the experiences that we've had. There should be proper training for research, and I hope that we avoid just one-off workshops and really institute a structured learning program for research and institute mentoring. Funding that can be as easy as listing down available grants that are available to you, just so it facilitates the process for your trainees. And big deal is actually just the administrative support, having an office space, having a statistician, and having protected time for research. The other thing, and I think ITRMC is on the right track here, is needing role models to build the critical mass of consultant researchers who can supervise and mentor your trainees. I think this is a long-term investment that it will pay off in the end. And lastly, if you remember the 40% earlier who does not want to do research, I think the best way is to also engage them in research, not on the production side, but maybe more on strengthening their ability to use research, understand research. And I think that's going to that should be the focus actually for all clinicians, is that they're very strong in their evidence-based medicine skills, in being able to sieve through all of the researches that are available and use them for actual practice. I've always tried to share this. No, there should be an emphasis on quality over quantity in research, and quality research doesn't have to be difficult. I think one of the things that I'd like to leave with the group today is that I hope you can explore with your health research agenda, explore low risk, high impact research designs that might really give relevance into the researches that you will produce for the next few years. One example of such low risk, high impact research design are actually quality improvement studies, which include time motion studies. We have had, and it's an ongoing study where we're looking at bottlenecks in the process of medication use process, actually, and the other one is actually on seeing where the bottlenecks are when a stat medication is actually ordered in the pharmacy up to the time that the medicine gets to be administered to the patient. So those are just simple, conceptually simple, and even implementation wise would be simple and low risk research designs that might have very high impact as far as improving your processes are concerned. As Doc Joel mentioned, designing institution-specific pathways and algorithms based on CPGs. Developing CPGs per se are actually very tedious. It requires a lot of work. So I think as far as hospital levels are concerned, the best way is really to use the current CPGs, appraise them for applicability in your institution, and design pathways and algorithms that will work for you based on those CPGs. One of the advantages of doing these high impact, low risk research designs, such as the QI studies, not only is that they're simple, they're easier to implement, but they also obviate the need for long ethics review process. In fact, there might be projects wherein you may waive the need for an informed consent from patients if research is of minimal risk, if it's not possible to obtain informed consent, and all data in the study will be collected as part of routine care. And there are many, I think you will, when you look back into your health research agenda in your departments, you can, I'm sure, identify QI researches that will not need informed consent from patients based on these criteria. The other thing that I think will make ITRMC really stick to its HRA and cementing its leadership in research is by involving itself in collaborative research. The whole process of collaboration in research, I'm sure you will all appreciate that it enhances generalizability of your data and your conclusions, and of course increases the impact because there are more. The magnitude and the extent of research is wider. And this is especially relevant for a big hospital like ITRMC. But when you try to think about collaboration, don't just think about multiple sites, also think about multiple provider types. And I'm seeing a lot of members of the other clinical and allied departments here. I'm sure there's room for us to do research where you have the doctor's perspective, the nurse's perspective, the pharmacist's perspective, all in one place, and seeing how all of these interact and improve on each other. The other possibility in terms of collaboration is putting on multiple perspectives. So you can have mixed methods where you integrate quantitative data with qualitative data, and that makes it a richer research project. And lastly, one of the advantages of this collaborative research is a higher chance of publication. So it's really a keyword with journals and editors. If we see collaboration, if we see multidisciplinary there, those are really positive words that can really put your papers into publication. The next here is that design your research program towards publication. And I've always said this, research is meaningless if it's not shared. Therefore, as Alan was saying, that you are cultivating a culture of research in ITRMC, I hope you can do a step further and cultivate a culture of publication in ITRMC. And that can be made possible if for your research planning, you already identify a journal for publication. Suffice it to say, each journal has its agenda and has its specific audience. And looking at the agenda and the audience helps you really plan towards publication. That being said, what I'm saying is every article also has a journal home. So if you've been rejected in one journal, that might not be the proper home for your research, and just try until you find the right journal that fits your research. Just be wary of the predatory journals, but definitely try until your research is published. And this is an important note. Many of the people I've talked about when it comes to research is that they're always looking at research to make it global or national in scope. But realistically, many journals, including BMJ, have an explicit lens on local context. So if your research is looking at your local situations, your cultural differences, showing your local challenges, especially with quality improvement studies, and how you were able to overcome them, those are really really nice things that would be helpful for you to publish your journal. So it's not always, global. And I think we should also always look at the equity lens in all of our researches. So don't be disheartened about not being able to go global in terms of scope. maybe one of the last things is keeping research and keeping actually the patient at the center of research. And I think this also goes with the quadruple aim earlier that I've mentioned, is that let's keep patient experiences, patient values and preferences in there at the forefront of all of our researches. Improving equity and access, and Dr. Beleno mentioned also about the vulnerable groups. I think some of the researches are just not done in the vulnerable groups just because ethics wise or technical review wise they're going to be much harder group to research on, but the data that we can get from these vulnerable groups are really valuable. So I hope people will really consider doing those researches. In our scoping of our research project on quality improvement with the AHEAD, we found that there are a lot of there are actually very few locally validated tools on patient-centeredness, and that might be one of the things that your group might look into. And lastly, there's a lack of emphasis on transitions of care. I hope that in your research planning, you can also look at these transitions of care, whether patients go from the ambulatory clinics to the inpatient, going from the ward to the ICU, or even just from hospital to hospital, as you were saying earlier about the referral networks, how integrating your patients are going to be, done from the hospital to the home and community, or even from your hospital to other long-term care facilities, such as those for the older individuals. I think there's a paucity of researches in that area, and have definitely high impact if we do get to those kinds of researches. Siguro lastly, before I end and set off all of you into research, maybe two questions or two comments, last comments for the group, is that I hope that the 6 core research topics in your research agenda is something that you can disseminate very widely in the hospital. If you should make infographics and make all of the walls in the wards and the ICU reflect your HRA, I think that's really going to be effective into making sure that all of your personnel and staff and trainees are always mindful of the health research agenda. And the last is a question to the group, which may be answered later, is that how do you intend to measure alignment of the researches that you produce from 2022 to 2025, I think, with regards to the research agenda that you put in. So I'm sure Dr. Joel Beleno appreciates this, is that in patient safety, we're always looking at setting targets and monitoring if we were able to achieve those targets. So my challenge to the group is, how do you now know, now that you've set your target, how do you know if you've actually achieved those targets at the end of that year that you've set your research agenda on? So with that, thank you again for listening, and I'll be happy to entertain questions later.